Welcome to this edition of the ICCS YouTube channel. This presentation is an excerpt from an ICCS webinar on monocytic neoplasms, which was originally delivered in January of 2024. In this presentation, you will hear from Dr. Xiuyuan Chen, who is a hematopathologist at the Fred Hutchinson Cancer Center and the University of Washington in Seattle. Dr. Chen will review immunophenotypic alterations associated with reactive or regenerative conditions, which can mimic monocytic neoplasms. Dr. Chen will also discuss strategies for MRD or measurable residual disease detection in monocytic neoplasms, a very challenging diagnostic area. Now, to access the entire webinar and to hear the engaging discussion that followed, we encourage you to become a member of ICCS. With no further ado, here's Dr. Chen.
These are the myeloid panels currently used by the UW HemePath lab. Tube 1 to evaluate blast population, Tube 2 to assess maturing myelomonocytic cells, Tube 3 to evaluate aberrant T-NK cell markers. The lab is currently validating an add-on monocytic tube. This is a modification of the myeloid Tube 2, including 3 additional monocytic markers. Leukocyte immunoglobulin-like receptor B1 and B4 are expressed on monocytic cells, and CD300E is expressed on mature monocytes. To emphasize the normal monocytic maturation pattern in the bone marrow, the black line follows the changes in antigen intensity as monocytes mature. Immature monocytic cells are colored in blue, mature classical monocytes in pink, and non-classical monocytes in orange. Monocytic cells have high-level expression of CD33 and 64 at all stages of maturation. The immature monocytic cells express bright DR and RB4, lower level of RB1, and lack CD14 and CD300E. With maturation, monocytic cells acquire CD14 and 300E, express bright RB1 and the lower level of DR and RB4. In the peripheral blood, majority of the mature monocytes are classical monocytes, with expression of slightly lower level of RB1, slightly higher level of RB4, bright CD14 and CD300E, and lack CD16. Non-classical monocytes express CD16 and show decreased to absent CD14. It's important to be able to distinguish between benign reactive immunophenotypic alterations and abnormalities associated with monocytic neoplasms. In reactive conditions, you may see reactive monocytosis, a left shift in maturation, expression of CD56, and altered levels of CD14, 16, and 64, among others. Additionally, you may see reactive changes in the blast compartment and in myeloid forms. In the setting of post-induction therapy, comparing to the normal marrow on the top, in the post-therapy marrow, the monocytes and maturing myeloid cells have variable CD56 expression, which is not present in the normal marrow. A small subset of blasts also express dim CD56. CD56 expression can be seen in marrow regeneration and often present in both myelomonocytic cells and blasts. Increased CD56 positive monocytes have also been described in autoimmune diseases. In Crohn's disease, the percentage of CD56 positive monocytes is significantly higher than the percentage in controls. Likewise, in younger patients with rheumatoid arthritis, the percentage of CD56 positive monocytes is significantly higher than the percentage in healthy controls. In this patient, we see a subset of monocytes lack CD14 expression, and a subset of neutrophils show decreased CD16 expression, forming an additional line of maturation. CD14 and CD16 are GPI-linked proteins. Loss of CD14 on monocytes and loss of CD16 on neutrophils can be associated with a PNH clone. The PNH assay performed on the peripheral blood identified a subset of GPI-deficient monocytes lacking CD14 and FLAIR, and a subset of GPI-deficient neutrophils lacking CD24 and FLAIR. It's important to recognize this pattern in bone marrow and not to misinterpret GPI-deficient monocytes lacking CD14 as immature monocytes. A peripheral blood pH assay is required to confirm the diagnosis and quantify the GPI-deficient clones. With the increased use of targeted therapy, you may see absence of targeted antigens on myelomonocytic cells, leading to change in normal pattern. Normally, CD38 is expressed on plasma cells and on blasts, and gradually decreased with myeloid and monocytic maturation. In this patient, CD38 is absent on all the populations, including myeloid cells, monocytes, and lymphocytes. The normal patterns of CD38 and 14, 38 and 33, and 13 and 38 are lost due to absence of 38 on monocytic cells and myeloid cells. It turned out that the patient was treated with anti-CD38 monoclonal antibody for multiple myeloma. Other targeted therapies, such as anti-CD33 and anti-CD123, have been used to treat acute myeloid leukemia and can cause maturation pattern change. Treatment history is very important to help pattern recognition and to avoid misinterpretation of a therapeutic effect as a true abnormality. Patients with Down syndrome without myeloid neoplasm have a unique immunophenotype on myelomonocytic cells and blasts. Virtually all monocytes and granulocytes show aberrant co-expression of CD33 and CD56. These cells are not morphologically distinguishable from normal granulocytes and monocytes. Blasts often have aberrantly increased CD33 on the CD56 positive subset. The proportion of 3 monocyte subsets in the peripheral blood may vary in different clinical settings. A decrease in non-classical monocytes has been described after treatment with IV immunoglobulin in CVID and blockade of the macrophage colony-stimulating factor pathway in active rheumatoid arthritis. The expansion of non-classical monocytes can be seen in a variety of clinical situations, including autoimmune diseases, bacterial and viral infections, asthma, stroke, and coronary artery disease. What other conditions can you see expansion of non-classical monocytes? This is a 54-year-old man with AML, day 28, post-chemotherapy. The CD34 positive myeloid blasts comprise 3% of the white cells in the peripheral blood and show a normal antigen expression pattern. The monocytes are expanded, accounting for 58% of the white cells and with variable CD56 expression. The monocytes include expanded non-classical monocytes and intermediate monocytes. These monocyte subsets show a normal antigen expression pattern consistent with reactive monocytosis. This is a 10-year-old boy presenting with thrombocytopenia and bruising. Flow cytometry showed a normal myeloid blast population. There is also an expanded non-classical monocyte population comprising 5.5% of the white cells, with expression of RB1, CD16, CD13, and decreased CD14. Most importantly, there is an abnormal T lymphoblastic population, representing 16% of the white cells, with expression of CD4 and CD1A. The patient was diagnosed with T lymphoblastic leukemia. The expansion of non-classical monocytes is often a part of the body's response to inflammation, infection, or other stressors. An increase in the classical monocytes had never been linked to a human disease until its association with chronic myelomonocytic leukemia was identified. In cases of reactive monocytosis and in healthy controls, the percentage of classical monocyte ranges from 79 to 86%. In chronic myelomonocytic leukemia, the percentage of classical monocytes was markedly higher, reaching 96%. Using a cutoff value of 94%, the specificity value was 94% and the sensitivity close to 92%. This accumulation of classical monocytes could indicate the abnormal differentiation of specific monocyte subsets. In a fraction of chronic myelomonocytic leukemia, the aberrant expression of CD56 is a characteristic feature of monocytic dysplasia, together with the decreased expression of DR and the aberrant expression of CD2. An initial diagnosis of chronic myelomonocytic leukemia can be challenging, in particular to differentiate from reactive monocytosis, prefibrotic myeloproliferative neoplasms, and other myeloid neoplasms with monocytosis. The monocyte dysplasia can be difficult to assess. Morphologically identified monocytes could include a variable fraction of dysplastic immature granulocytes. CD56 expression on monocytes is not specific and can be seen in reactive conditions. The increased classical monocytes can be rapidly detected by flow cytometry on peripheral blood and can be used to improve the sensitivity and specificity of a diagnosis of chronic myelomonocytic leukemia. This increase in classical monocytes disappears in patients who respond to hypomethylating agents, so monocytic subset profile is also a biomarker of response to therapy. Monocytic neoplasms can be challenging to diagnose, as other hematologic malignancies or reactive inflammatory processes may mimic monocytic neoplasms. The patient is a 2-year-old girl with skull lesion. This is left parietal FNA. There is a mature monocyte population with bright CD64 and CD14. Additionally, there is an atypical population with expression of monocytic markers, including bright CD4 and 33, variable DR, CD64 and CD14. The atypical cells are large, with grooved and folded nuclei, and abundant pale cytoplasm with vacuoles. Additional tube showed the atypical population has bright CD1A expression, while normal mature monocytes are negative for CD1A. The diagnosis is Langerhans cell histiocytosis. This is a 65-year-old woman with a long-standing CLL who developed lymphadenopathy. In the bone marrow, there is an abnormal lymphocyte population with aberrant expression of CD5, dim CD20, and dim kappa light chain expression, consistent with CLL. Additionally, there is an typical population with some monocytic marker expression, including CD4, 13, 33, and aberrant CD56. Morphology showed involvement by CLL and a transformed histiocytic sarcoma. In both cases, the atypical population expressed some monocytic markers, but additional analysis and morphologic correlation demonstrate histiocytic neoplasm rather than myeloid neoplasm with monocytic differentiation. Knowing the reactive immunophenotypic alterations and mimics is crucial for MRD assessment in monocytic neoplasms. MRD detection relies on the immunophenotypic principle that leukemic blasts, blast equivalents, and maturing myelomonocytic cells show altered pattern of antigen expression different from normal progenitors. It is recommended to use a combination of two related methods to improve sensitivity: leukemia-associated immunophenotype and difference from normal. There are challenges in MRD detection in monocytic neoplasms. Blast equivalents may be CD34 and CD117 negative, so you can't rely on blast marker to gate abnormal cells. You need additional marker to confirm immaturity. Most labs rely on lack of CD14 as a feature of monocytic immaturity. CD14 staining pattern is clone dependent. Some anti-CD14 clones may recognize pro-monocytes in addition to mature monocytes, so lack of CD14 is not always a reliable marker of immature monocytes. In patients with underlying myelodysplasia, dysplastic myeloid cells may have aberrant myelomonocytic antigen expression, and to separate immature monocytes from dysplastic myeloid progenitors is difficult. Morphologic assessment will likely provide clue and accurate blast enumeration. CD56 expression is not specific and cannot be used as sole evidence of neoplastic monocytes. Let's look at some examples. This is a 12-year-old girl with a history of AML, KMT2A rearranged. Bone marrow was sent to us for MRD flow. On CD45 versus size scatter plot, blast gate is defined by dim CD45 and low size scatter. From the blast gate, we gate CD34 positive myeloid blasts, highlighted in red. All plots show CD34 positive blasts. The top is from normal, the bottom is from the patient. Comparing plots from normal to plots from the patient, the antigen expression pattern of the blasts are quite similar. There isn't a distinct subset sitting outside of normal maturation spectrum in the patient. Can we conclude this is MRD negative? Let's go back to CD45 versus size scatter plot to check the blast gate. Outside of the blast gate, there is an uncolored population in yellow circle with intermediate CD35 and size scatter. There are not lymphocytes, mature monocytes, or maturing myeloid cells. Let's expand the blast gate to include this population. Now all plots show cells in the expanded blast gate. We found this orange population in all three myeloid tubes based on CD45 versus size scatter. These cells express CD38, 15, 117, bright CD33, 56, 123, 64, and 4, and are negative for CD13, 14, and 34. The immunophenotype is compatible with abnormal immature monocytes, 5% of the white cells. There are normal CD34 positive progenitors in the background, highlighted in red, showing a normal maturation pattern. In this case, the abnormal blast sits outside of typical blast gate. If you only focus on the cells in the blast gate, which show the normal antigen pattern in this case, you may entirely miss the abnormal cells that represent MRD. CD45 versus size scatter gating is an initial strategy for blast identification in many clinical labs and provides a useful starting point to distinguish blasts from other maturing cells. But not all blasts reside in the blast gate. There are exceptions. Immature monocytic cells in acute monoblastic or monocytic leukemia have higher CD45, overlapping with mature monocytes, so more likely appear in the monocyte gate. Abnormal promyelocytes in acute promyelocytic leukemia have a high size scatter, more likely appear in the granulocytic gate. Abnormal proerythroblasts in acute erythroid leukemia have low CD45, so are out of the blast gate, but can be confirmed by CD71 and CD117. Abnormal macrocytic blasts in acute macaroblastic leukemia have low to absent CD45, so are also out of the blast gate, can be confirmed by CD41 and CD61. In the diagnostic sample, the blast population is expanded. Even if the blasts are not in the blast gate, you will not miss an expanded population. However, in the post-therapy setting, blast population is small. Blasts with challenging immunophenotype may be missed if you only focus on the cells in the blast gate and CD34 positive gate. All populations in the different gates should be carefully evaluated to avoid missing an abnormal blast population. This is a 37-year-old man with a history of AML with monocytic differentiation. Bone marrow sent to us for flow MRD. On 45 versus size scatter plot, blast gate is defined by dim CD45 and low size scatter. From the blast gate, we gate CD34 positive myeloid blast, colored in red. All plots show CD34 positive blast. Comparing plots from normal to plots from the patient, the antigen expression pattern of the blast are quite similar. There isn't an abnormal subset sitting outside of normal maturation spectrum. Can we conclude this is MRD negative? Let's go back to the blast gating. Instead of CD34 and CD19, let's look at CD34 and CD117. There's a small CD34 negative, CD117 positive population sitting in the blast gate. This population represents 0.03% of the white cells and expresses CD38, bright CD13, 33, and 117, and the variable DR without CD34. In comparison with normal monocytic maturation, the patient's monocytes contain two subsets. The pink subset is mostly mature and show a normal pattern. The aqua subset expresses bright CD64 and 123 and lacks CD40 and 16. It also expresses CD33, 15, DR, and CD4, consistent with an abnormal immature monocyte population, 4% of the white cells. To identify abnormal immature monocytes, first we need to confirm the maturity of monocytic cells. Some immature monocytes may express CD117. They should lack markers acquiring during maturation, such as CD13, 14, and 300E. Then to look for immunophenotypic abnormalities. Strong uniform expression of CD56 is more specific than variable CD56 on a subset. They may have altered intensity of a list of myelomonocytic antigens. These aberrancies would help you distinguish blast equivalents representing MRD from left-shifted monocytic maturation. How to distinguish immature monocytes from non-classical monocytes. Although non-classical monocytes have decreased expression of CD14, similar to immature monocytes, non-classical monocytes express CD16, CD13, and often decreased CD64. In comparison, the patient's immature monocytes are negative for CD13, 14, 64, and have increased CD64 and HLA-DR. Take-home messages. MRD detection in monocytic neoplasms can be challenging. There are some strategies that can be applied to data interpretation. Keep in mind, blasts do not always reside in the blast gate, defined by CD45 and size scatter. Always expand the initial blast gate to display more cells until all subsets are accounted for. The immature monocytes may lack CD34 and 117. It's helpful to display both CD34 positive blasts and all events in the blast gate, which may catch 34 negative blasts, specifically to look for abnormal CD34 negative and 117 positive progenitors. The patients may have abnormal myeloid blast population and immature monocyte population at the same time. In cases with immature monocytes that are difficult to confirm immaturity or to separate from dysplastic myeloid cells, the identification of abnormal myeloid blast population is helpful to reach the right diagnosis. Knowledge of history and diagnostic phenotype is always important and can provide clue in challenging cases. In low-grade monocytic neoplasms, such as chronic myelomonocytic leukemia, MRD detection may not be informative by flow cytometry. Myeloid gene panel by NGS to look for gene mutations may be helpful in these scenarios. Here's a reference list. Thank you.
Thank you for your attention. Again, to access the entire webinar and to hear the engaging discussion that followed, we encourage you to become a member of ICCS. If you enjoyed this video, consider subscribing to the ICCS YouTube channel. And for more resources on monocytes and all topics flow cytometry, you can visit the ICCS website. We have lots of useful resources there if you're interested in flow cytometry. And with that, we'll close. Thank you again for your attention and see you next time.